Okay, so today we're going to be talking about menopause, hormones, and female health. And I thought it would make sense to break it up this way. First of all, let's just talk about what we mean by the menopause. I'm not sure everyone knows precisely what that means, and I wanted to clear up any questions about that. I wanted to talk with you about symptoms that many women, not all, experience and what our expanding menu is, as I like to call it, for being able to address these symptoms. And then finally, I wanted to just talk about some, really throughout the talk and then at the end a little bit, some of the special considerations, excuse me, for women who are living with diabetes. I like to say that the menopause offers us a portal or an entryway to the second half of life. So I'll tell you what I mean about that. So let's start with a quiz, and we're going to sort of use this as a way to have you participate. First of all, menopause is defined as the reverse of puberty. Well, sometimes it might feel like that. B, the final menstrual period. C, the end of female fertility. Well, certainly female fertility is way declined by the time we get to the time of our lives where we are entering the menopause transition. But I don't want you to misinterpret that. And I want to be very clear that if you are still vulnerable to conceiving, if neither you nor your partner have taken any permanent steps for contraception, you're going to want to keep some kind of contraception going until you're distant from your menopause. Or sadly, D, do you think it's the beginning of the end? I hope not, because I think it's really a marker. It's an important transition. We experience some ups and downs during this time, but I hope you don't think it's the beginning of the end. And so the answer really is the final menstrual period. So if we look at women's reproductive life, really from puberty would be off the screen a little bit to the left, all the way through our later years. Menopause is really just a single point in time. It is indeed the final menstrual period, but we can only diagnose that retrospectively or looking backwards after we haven't had any periods for a year. And this is because this transition can be so on again, off again. We want to make certain that we don't necessarily call a person fully postmenopausal until she really is. So this topic is a good one. This topic is something that I've been thinking about for a very long time. I was quoted about almost 30 years ago saying that mothers do a good job talking with their daughters about menstruation, but they don't talk much about menopause. And so this book, Megatrends, which some of you might have heard of, came in, and the author said, neither does anybody else, but the demographics behind the menopause megatrend are about to change. So it's important how we deal with this. And it really is interesting that the number that's quoted now, or at least at the end of 2020, was that by that time, we'd have about 50 million women age 50 or more. So that's a lot of menopause happening. And sure enough, this was the New York Times a couple of years ago that talked about puberty for the middle age. So maybe that reverse of puberty thing was only partly a joke. And they go on to say, if only on your 45th birthday, a doctor would sit you down, look you squarely in the eyes and say, here's what's going to happen. Wouldn't that be a good thing? And then they said the same thing that I did. We put a lot of time and effort into preparing our teenagers, but we really don't address well enough another kind of puberty, the perimenopause. So ladies, today, I'm going to look you in the eye. I'm going to tell you what's going to happen. I'm going to tell you what your choices are to possibly moderate this experience a little bit and make it just as good as it can possibly be. So the perimenopause, again, is a transition of a number of years. The years before menopause, when most women start to know that they're having changes in their menstrual cycle, and for a year after the final menstrual period. And it's a time when we acknowledge that symptoms can begin, and symptoms can get pretty bad. Those symptoms being particularly vasomotor symptoms, also known as hot flashes. Some women have altered mood. They might feel depressed or have some anxiety, and they might notice that they have trouble falling asleep, or what I think is worse yet is awakening in the middle of the night and can't get back to sleep. And then some vaginal and urinary symptoms that fall under a relatively new category that we call genitourinary syndrome of menopause. So what additional challenges arise for women living with diabetes when they enter this transition? I think one of the major ones that I've been told about again and again by women is it can be really tricky sometimes for any woman to recognize what a hot flash feels like when they first start happening. But particularly sometimes women with diabetes have a hard time deciphering between a hot flash and between entering into a low blood sugar or an episode of hypoglycemia. So the only thing I can say is as these decades have gone by, that such better options for monitoring your blood glucose. Maybe you even have a continuous blood glucose monitor system so that you can hopefully, nail this down without too much challenge to be able to say, yep, this is a hot flash. I don't need to boost my blood sugar, or this feels like it's the real thing. We also know that many women have told me that when they monitor their blood sugar over the course of a month, they just notice that in that week or so before their period, and they say, I'm not eating differently, I'm not exercising differently, but wow, I'm just not managing my glucose as well. The same level of therapy, be it insulin or other therapies, is not seeming to really take care of it. So in the menopause transition, unfortunately, we add on really some pretty major fluxes of hormones. Estrogen levels can be very high, they can be very low. And sometimes women ovulate, sometimes they're going to have those luteal phase hormones that can make managing your blood sugar more difficult. Sometimes they won't. So just, I would say, fasten your seatbelts. Be aware that you may have difficulties with management. But I think it helps so much if you just know what's going on. And you also know that this shall pass. This is not a forever thing. This is a temporary experience. Some women notice that they gain weight, or that even if they don't gain weight, that weight is redistributed on our abdomens. It's can be unpleasant, unsightly, annoying, however you want to call it. But we know that that has metabolic effects. And so again, for women with diabetes, might see changes again in the glucose management, their blood pressure, lipid changes that can be deteriorating during this time. And then finally, I already mentioned the menstrual cycle irregularity. But for those of you who have super heavy periods, who seem to last for days and days, be sure to check this out with your doctor if you see an OBGYN or your primary care doctor. We want to make sure that this is just all due to those hormone fluxes of the menopause transition, but not related to any abnormalities within the lining of your uterus. And heavy bleeding can be a sign of changes that could be related to endometrial cancer. So just get it reported and get it checked out, and it'll put your mind at ease. So when does all this happen? When does menopause occur? So let's do another quiz. Menopause will happen the same age as my mother. I've had so many women ask me about that. And while genetics are probably have a role, it's not a guarantee that you're going to be the same as your mom. Everyone says by the time I'm 50, so hello, I'm 52, nothing's happened yet. I'm going to show you 50 is the average age, but it's certainly not the upper age that it can happen. C, when the eggs run out, well, certainly the number of follicles in our ovaries declines over the time of our life. This really does speed up in the years before menopause. But again, as I mentioned before, watch Mother of the Bride, part 2 again, they call them change of life babies. The eggs aren't completely gone. So please don't be lulled that since you're going through this transition, you can't get pregnant. Got to stay on that game for a while yet. And then the last point is about 2 years after skipping periods. And in fact, that really is the correct answer. And we know when we monitor women's menstrual cycles, some of you might do this on an app, we know that women can start to notice that they're actually skipping periods. And so they might go for 60 days, like 2 months without a period. When that starts happening with some regularity, that's a pretty good clue that you're probably within a year or two from when you're going to finally go through menopause, when you're going to finally stop menstruating completely. Unfortunately, we don't have better predictors right now. You can't just say, can I have a blood test? Can I have an anti-malarian hormone? Or can you do an ultrasound of my ovaries? We just can't really predict it in an individual woman that well yet. But believe me, people are working on this. Okay, so what is the average age of menopause? 46 to 55. That's a pretty good range. If you're a little bit older than that, you're not going to be in the Guinness Book of World Records. But if you're younger than that, we pay attention. because we know that women who have early menopause between the ages of 40 and 45 often have an association with an added risk of cardiovascular disease. We don't know if this is because their estrogen levels are lower earlier and our body is kind of programmed to have about really 40 years from the time we start puberty till the time we go through menopause of estrogen, or if there's something else systemic going on with women who have an early menopause, and really just kind of a little more premature aging also goes along with an earlier menopause. This is another area where people are really thinking about and actively investigating this right now. The third category is premature menopause, and these are women who have a really early menopause before the age of 40. And we know that that can go along with a number of other conditions. Probably for a woman with diabetes, one of the things that your doctor or your practitioner is going to think about is, could your early menopause and your diabetes be a hint that you might have some other immune system disorder that could contribute to other endocrine glands like your thyroid gland or like your adrenal glands not working quite up to par. And so that's something that your doctor might want to look into if that occurs. So again, flip side, like many things in life, the good news about menopause is that, a lot of women feel liberated. You're not having to go through the inconvenience and discomfort of monthly menstrual cycles. I can imagine a number of you, every time you buy a box of tampons, saying, is this the end? Is this the last one? Some women, not all, but some women really do notice as they approach menopause that the mood swings that can occur during the last half of the menstrual cycle can get much worse. That's gone once you go through menopause. And then finally, no more worries when you're a year since your last cycle with contraception or risk of unintended pregnancy. And for many women, this is always awareness. And so you don't have to worry about that anymore. So we talked a little bit about some of the hot flashes. It can be an annoying symptom for women. For many women, probably the vast majority of women, these come on, they last a while, and eventually they go away. There is a smaller group of women, about 20%, for whom hot flashes can start even a decade before they go through menopause. And in some longitudinal studies that follow women from well before menopause to very long after, at 10 years or a dozen years past menopause, a small group of women are still having hot flashes. So again, we don't know a way to identify if that's going to be you or not. For the most part, vasomotor symptoms will get better. Similarly, some of the mood symptoms that bother women during menopause get better. Sleep disorders, memory fog, brain fog gets better. Some of the genitourinary symptoms, which I'll talk about a little bit more, as opposed to the hot flashes, will often get worse. So that's something we're going to address separately because I want to make sure that you know about that. And then osteoporosis and cardiovascular disease are issues beyond menopause, really, for all women. So what's the best approach to treating these symptoms in women who are living with diabetes? Well, we really, I can't make a blanket statement for all women because you're just so different. We're all so different. And so we really like to emphasize an individualized approach. What is it going to take for you? And so there are a couple things we look at. Number one are your symptoms. How bothered are you? I've had women describe symptoms and I feel like, whoa, this is pretty intense. She's going to want treatment. And she goes, no, Dr. Stuenkel, I'm doing okay. This is not that big a deal for me. And then the flip side's also true. Some women, a little hot flash, a little disturbance, a little extra perspiration, and they're ready to I want this to go away. I don't like it disrupting the meetings I'm running. Please fix this now. So an individual sense of bother. The other thing is what do you want? Do you have ideas about what you might think would be the best course for you? I think that's real important to be aware of and to discuss with your provider. Some women, I think we're herd creatures. We talk to the women, and I have a book club. We talk to women in our carpool. We talk to neighbors and family that are strong influences in us as we decide the way to go on some of these things when it's not just like a black and white choice. So, what are you thinking is something that you might want to do? And then finally, when I talk to doctors about this and to healthcare providers, Our job is to make sure whatever route you take is going to be safe for you. And I'll tell you some of the ways that we do that. So the first is when we look at this menu of what we have available for treatment of hot flashes, it's pretty impressive. We have some lifestyle choices. I'm in Southern California. We have some mind, body, and behavior. There are non-prescription therapies that you may see wandering through, aisle number 4 at Costco. These have some pretty impressive descriptions on the bottles, but please just know that most of them have not been tested to see if they work in randomized controlled blinded clinical trials, or how safe they are over the long term. So not an enormous amount of enthusiasm for some of these therapies. There are some prescription therapies of FDA approved drugs. Most of these, and I'll go through these in detail, interestingly, aren't necessarily approved for hot flashes per se, but they've been approved for other indications. And then in clinical trials, it's been shown that they also are good for hot flashes. So I'll show you some of those because I think there's some interesting kind of what I call twofers available, that you get one benefit and another benefit from the same treatment. And then finally, estrogen, which has been around for a very long time. We keep learning more about and has been obviously one of the most effective treatments for some of these symptoms. So here's another question. Hot flashes can be reduced by cognitive behavioral therapy. What is that? Hypnosis. Hypnosis is something you remember seeing like in a comedy club or maybe I remember high school assemblies, we'd have a hypnotist come in. Or drugs for depression, nerve pain. Maybe some of you have some nerve pain with your diabetes and use a nerve pain drug. Or overactive bladder. Well, the surprising answer for this is yes, all of the above can be effective at reducing hot flashes. And so just to go into that a little bit more detail, I was kind of surprised when the North American Menopause Society went through this a few years ago and said that indeed cognitive behavioral therapy and clinical hypnosis were up at the top of the list for benefit to hot flashes. So this partly just says to us that we don't necessarily really understand everything about how these hot flashes are generated and why things like the kind of disciplined thinking and sort of thought control with cognitive behavioral therapy or hypnosis might be effective, but they are. And that's good news for women who can't or shouldn't use hormone therapies. Finally, of the prescription drugs, there's a number. So paroxetine salt, also called Brisdil, is only one of these is currently FDA approved for the use with hot flashes. But there are a number of other antidepressants, the gabapentinoids for nerve pain. Clonidine is on the list for hypertension, though there's a lot of side effects with that. We don't necessarily really recommend that. But down at the bottom, you can see that oxybutynin, which is a drug for overactive bladder, a group of colleagues at the Mayo Clinics listened to their patients who said, this is helping with my urinary frequency, but you've got to know that this is also helping with my hot flashes. So they did a study on it and they found that it was true. And then the most recent one I've heard about is lorcaserin, which is a drug for weight loss. What perimenopausal woman isn't going to be excited about taking a drug for weight loss and helping her hot flashes at the same time? So whether, you have some depressive symptoms and you can get the benefit of the SSRI, SNRI, whether you have trouble sleeping, the gabapentin makes a lot of people tired. Women can take that at night. We're trying to make it so that these provide a couple different benefits, not just the hot flashes. And then there are a number of other things that I think are worth mentioning. Weight loss, and they call this recommend with caution, not so much because these are dangerous, but just because the data for these may not be as compelling as for the ones that were recommended. But there have been trials that women who lost weight reduce their hot flashes. That might be a motivator. Stress reduction, what's to argue about that? We know it's good for us in so many ways. S-equal is in the family of some of the soy agents, and this has some data that may be effective. And then finally, for women who sometimes have had breast cancer and really just aren't getting relief from any of the drugs and can't or don't want to use hormone therapy, a much more interventional kind of procedure called stellate ganglion blockade can be helpful, but this is still a little bit investigational. And then things like, setting down your thermostat. Your partner can put on a sweater if they're chilly, knowing what triggers you. In a NIH-funded trial called MS Flash, they looked at exercise and yoga, and they said, well, it didn't really help with the hot flashes, but the women just felt so much better. They just didn't care as much. So a lot of different approaches. Acupuncture, if it's a reputable place and uses clean needles and you think it works and you can afford it, then go for it. So a lot of different ways to skin this cat. But I think the main take-home point is there are a lot of things that we can do to get more comfortable shy of hormones. I want to just quickly tell you about something coming up, and you might be saying, usually we don't see pictures of candy in our Take Control of Your Diabetes presentations. So this helps me to remember this acronym KNDY, which stands for the names of some complex interrelated neurons in our brains, kisspeptin, neurokinin B, and dynorphin, that actually modulate temperature and we think have a very compelling role in setting off hot flashes. So this is an interesting story. These drugs were kind of on the shelf after having failed for treatment of schizophrenia, a very serious mental health disorder. And somebody remembered that they must have had some effects either with hot flashes or they knew about the mechanism of these drugs. So they tried them out, and indeed, these drugs have been incredibly effective. Hot flashes are reduced literally within days and dropped down from serious to almost nothing. So these drugs, and there are several of them in the pipeline, are currently being evaluated. They have not been approved by the FDA yet, but I can tell you that there's a lot of enthusiasm and these are coming soon. So I'm looking forward to seeing more data about these, to seeing more safety data about these. But I think it's kind of nice to know that, the menu is expanding. You're going to have some options. So what about menopausal hormone therapy? Is this a good choice for you? And that's really what I think many women deliberate about. So let's do another question. The single most important factor for women living with diabetes to think about when they're considering hormone therapy is bone health. Well, that's an important thing because we know that whether it's from the blood sugar or some other metabolic change, that women with diabetes might be more vulnerable to fractures. So bone health is important. Breast health, everyone needs to be, on their game with breast health, making sure that we're getting mammograms, doing what we can do for prevention. Heart health is something that we think about in many ways. And then finally, brain health. And I like to say that my brain is one of my favorite organs, but I've been really heartened in recent years to see all the data that supports the idea that if you take care of your heart, that's probably some of the best things that you can do to take care of your brain. So having said that, heart health is what I think is the most important factor that we can think about. So one of the things that I wanted to review with you as we go through this is what are the risks and benefits of hormone therapy? What do we know about the individual potential risks of hormone therapy to a woman who's thinking about it? So the Women's Health Initiative was a clinical trial that ended almost 20 years ago with the initial findings. But through the years, this data has been analyzed and massaged, and these women have been followed. And so we've really been able to learn a lot from this trial about risks and benefits. And one of the main things we learned is that women do best and it's safest if we use these hormones when we're under the age of 60 and we're within 10 years of our menopause. So what this chart shows is really a distilled down the data from this trial, looking at how many events per 1,000 women aged 50 to 59 who use these hormones for 5 years. So 5 years is kind of what most of us think about recommending, 3 to 5 years, because we know that there can be some increased risks. So on the top of the graph, we look at combination estrogen and a progestin, the second hormone that's used to protect the lining of the uterus. When the WHI was started, the most commonly prescribed drug in America was conjugated equine estrogens, or Premarin, at a dose of 0.625 milligrams, and it was given with Provera at 2.5 milligrams a day. For women who didn't have a uterus, they just got estrogen alone. And what you can see is that the risks are shown in red, the benefits are shown in blue. And let's look at an example of a number, because I just said that heart disease is important. So 2.5 women in 1,000 age 50 to 59 who use these hormones for 5 years will experience a heart attack. So you might go, that seems terrible. Or you might go, really? That's all? Why was I reading about stuff like 25% or 30%? So the actual numbers, when we look at the absolute risk, I think are pretty small. How about breast cancer? A lot of us think about breast cancer. 3 women per 1,000 on the combined therapy over 5 years. Some women will go, those odds sound pretty good to me. And others of you might say, there is no way I would ever take that chance. There are benefits to fractures. There are benefits to diabetes with these oral therapies. Interesting, right? That the oral estrogen helps with metabolism. So the only other thing I would say about these numbers is that we currently recommend doses half that were used in this trial. So we think that is associated with a lower risk of all these cardiovascular things, and probably the breast cancer too. And the second point would be that we often recommend transdermal therapies now, somehow absorbed through the skin, versus oral therapies for the same reason, because we know the oral therapies are metabolized by the liver and they can be associated with an increase in the risk of blood clots. So let's go on. So how do we assess? Well, we look at women, and first of all, if you're over 60 or you're more than 10 years since menopause, you probably ought to use one of the other therapies I went through. We know that our arteries keep aging, and we just don't want to take a chance on setting something off by getting people started on a hormone therapy later in life. So if you fit within the under age 60 or less than 10 years, you get the green light. Then we want to look at things called contraindications. What are aspects of your history that would make us not want to use hormone therapy with you? And so here's what they are. Number one, could you be pregnant? And if, again, you're not using contraception, going to want to check that out. Could you have bleeding because there's something going on with your cervix or your uterus? Your doctor is going to ask you to check that out. If you have a history of tumors that are sensitive to estrogen, like a breast cancer or a history of a uterine cancer, that's something that's going to make us say, let's try another option in general. And if you have a history of any cardiovascular events, stroke, heart attack, blood clots in your legs, blood clots in your lungs, we're going to say, let's not take a chance. And the liver dysfunction ties in because, as I said, the liver is where we metabolize these hormones. So severe liver disease would be a reason. And what about cardiovascular risk? Again, any sort of heart events in your history, even bad peripheral artery disease would be reasons to go, let's try something else. But if your risk is okay, you get a green light. So how do we do that? Well, both the Endocrine Society, the North American Menopause Society say, we think this is worth going through one of these risk calculators. We want to come up with a number. And so these are available online. A lot of your doctors might be already just doing this in their office. Sometimes if people are right on the fence and it's hard to know, are you at intermediate risk or high risk, they'll advise doing something called a coronary artery calcium score, which can be, I think, a tiebreaker, often used to decide, are you a candidate for statin therapy or not? But I think it can also help us know where you're at with cardiac risk in this setting. So we really break this down: 10-year cardiovascular risk, low, medium, or high. And in general, for women who are at low risk, we've always said that the sky is the limit. But if they're at moderate risk with things like metabolic syndrome or treated hypertension, then we recommend that those women think about using a transdermal therapy. So what about women with diabetes? Another group has looked at this specifically in women with diabetes. And I like it young as under 60. so that if these women have a low calculated risk and normal weight, then an oral therapy, these experts thought was okay. But if they have moderate risk or you're obese, then probably transdermal would be best. And I think these are reasonable recommendations. Breast cancer risk, there are calculators to sort this out. If you have breast cancer running in your family and you're worried about that, if you have an acceptable risk, then the thing that most of us would require, nobody's going to write a prescription for any of these hormonal therapies without knowing that your mammogram is up to date and it's okay. So please don't put that off. I know that sometimes you have so many other things when you're living with diabetes that you're trying to keep track of, but please, maintain these preventive things, particularly with your breasts. And then the final factor is, do you have a uterus or not? And so no uterus, that's easy. Estrogen alone is fine. If you do have a uterus, then we have a couple different approaches we can use to protect the lining of the uterus from the risks associated with using hormone therapy. Now, about this time, people are going, this is too much work. I'm starting to lose my attention. But I like to say that there's an app for that. So I think some of you who are just approaching menopause, thinking about this, I know you're very facile. Pick up your phone, pick up your laptop, and you will be able to look through this, and you can run it through a couple different ways and really get a good sense for where you stand and whether or not this makes sense for you. So specifically what hormone therapies are available, these are the oral doses. Again, as I mentioned, we're currently recommending about half the dose that was used in that Women's Health Initiative trial. And we accept that these may not completely take away your hot flashes, but we think they're safer from the standpoint, particularly of cardiovascular events, blood clots, and maybe breast cancer too. The transdermal therapies, which we think are even safer from some of these standpoints, come as a patch, different kinds of patches, lots of different sizes of the patches, gel, lotion. So again, there's quite a number of choices that you have. This is what one kind of patch can look like. Some of them are much smaller, but again, we know that they are what I like to call more metabolically friendly on a number of factors. And so for this category of patients, we like to say that we feel that our patients are taking a safer approach if they use a transdermal therapy. So if you have hypertension, obesity, diabetes, you can see is loud and clear on that list. And so that to me would be my first choice advising women. Again, the progestogen is only for women with a uterus, and the whole goal is to prevent endometrial, the lining of the uterus, overgrowth, and cancer. A number of different options, a number of different ways this can be used, including an intrauterine device that actually releases the progesterone right into the lining of the uterus. This has gotten some traction, and it's really thought to be beneficial in women who have excessive bleeding, irregular bleeding, who have been evaluated and know that they don't have a uterine cancer going on. And it also provides contraception. So some women are starting during the rocky road time of the perimenopause transition with one of these intrauterine devices. And then gradually this will lead to a thinning of the lining of the uterus. They will stop bleeding. And then if they start having hot flashes, then you can go ahead and add an estrogen on at that time with the intrauterine device in place. And these can stay for like 7 years. So, not for everybody, but for some women, this can be a really good choice. If you're going to take a treatment in general of the preparations available, just as we're looking for a metabolically friendly estrogen, we think the oral micronized progesterone is probably the best approach. I want to just let you know about one other regimen that's fairly new in the last years, combining the same kind of estrogen in the WHI, but a lower dose, with a drug in the same category as tamoxifen, you might know about for treating breast cancer, or raloxifene. It's called basidoxifene. And it really does, as you can see looking down this list, it does all the things that we want estrogen to do to relieve the symptoms of menopause. But we think that this might be a little bit safer for the breast, though we don't have long-term treatment right now that reassures us of that. But it's something to think about and something that might come up in the future. And the last thing I really want to say about hormone therapy, living in Southern California, is that there's a lot of action in the compounded world here and in other parts of the country too. And in some of the surveys that we did through the North American Menopause Society, we found that of younger women starting hormone therapy, almost 40% elected to use compounding. The problem is that these things aren't approved by the FDA, and the FDA doesn't really regulate the content, the safety, the consistency, um, no scary package labeling with the compounded. So I think it can kind of give women a false sense of security. And so the Endocrine Society, as well as many other groups that manage women's health, including last year, the National Academy of Sciences looked at this and said, we don't see any reason why women need to use compounded hormones during menopause, because we have so many FDA approved hormones that still have the quote bioidentical chemical structure, meaning that the chemical structure of these particular preparations match those that our body makes. And so if if you're on the fence about this, if you've been thinking about this, I'd really like to appeal to you to at least consider that using an FDA approved preparation will give you and your provider a lot more peace of mind. Okay, so how long should you use hormone therapies? We suggest that this should be reviewed annually. Again, I mentioned kind of 3 to 5 years, though this is not hard and fast. And this is something that, again, is individualized, that we want to look at what else is going on with you. How is it agreeing with you? Sometimes women want to stay on it longer, but we can like dial the dose down a little bit. Maybe if you've been on an oral therapy, change to a transdermal therapy with time. So not to be dogmatic about when it needs to be stopped, but to be sensible, because as we age, the question keeps coming up, is this still safe? So let's just turn as just another little point of review. This is to talk a little bit more about the genitourinary syndrome of menopause. This is a 60-year-old woman who reports that her last menstrual period was 5 years ago. She felt pretty symptomatic at the beginning, but she was put on a low dose of estrogen therapy and she feels better. But her main complaint now is this vaginal dryness. Her husband has recently been prescribed a little blue pill, and I bet you know what that is, which has done wonders for his ability to achieve and maintain an erection. So she's kind of feeling like the deer in the headlight who's been caught unprepared for him coming home. I mean, these drugs work pretty fast. Take them and it works. So she wants to know what can be done. And so when I talk to doctors groups, I always emphasize to prescribers, I say, if you're writing a prescription for one of these drugs for Cialis or, whatever, there's a number of them available now, the little blue pill Viagra, be sure you say to the man, maybe you want to make sure that your wife or your partner is up to speed for this, because intercourse is a lot more comfortable if you don't have a dry vagina. So this just kind of introduces a genitourinary syndrome of menopause. It certainly involves the vagina, but I think also can involve the urethra and the bladder. So things like recurrent urinary tract infections, things like dysuria, the feeling like you have to urinate all the time. And if these treatments are bothersome, then you can use treatments for these. You don't have to be using systemic estrogen, and I'll show you some of the treatments that we have available. And again, we have a reasonable menu so that these can be individualized for what's going to work for you and what you prefer. So here's our stepping stones again. Lifestyle just says that if you're on the front end of this, just that healthy, regular intercourse can be a positive maneuver for keeping the vaginal tissues healthy. But some women are just, even, with the best intentions, really suffer because of vaginal dryness. This is a time when I think you might want to take a look at that aisle of your drugstore that has things like vaginal moisturizers and vaginal lubricants. The moisturizers are recommended to be used pretty regularly to help just keep the tissues moist and healthy. And then there are a number of lubricants specifically for use during intercourse. Now, this woman was taking systemic hormone therapy, but as we dialed the doses down, we find that some women will still go on, even if they're still taking a low dose of hormone therapy, and develop some vaginal dryness. So don't just think, oh my gosh, this can't be happening because I'm already taking something for my hot flashes, because it can. And the other kind of systemic therapy is a selective estrogen receptor modulator that I'm going to show you about, as well as some vaginal therapy. So let's take a look at those quickly. So the vaginal therapies, this is starting with the estrogen preparations. Again, estrogen is the most effective. Comes as a variety of preparations and vaginal creams. And usually these things are used every day for, say, 2 weeks. And then after that, it can be twice a week, once a week. Women get pretty good at titrating their own dose, deciding how much they need. So it could be a cream, it could be a ring. This is kind of reminiscent of the diaphragm for contraception. It's a silastic ring. It's placed, it lasts for 3 months. Women have intercourse with it, and that can be very helpful. Vaginal tablets, again, are usually twice a week after the initial 2 weeks of therapy. And then the vaginal inserts are usually every single day. People always ask, and if you're just using a vaginal estrogen, a progesterone is not required to protect the lining of your uterus. These are incredibly low doses. They're not going to help your hot flashes. You shouldn't be getting breast tenderness. If either of those happen, you're getting too much. You need to go back to your doctor. But if you should bleed, this is a reason to really get in touch with your doctor, because they shouldn't be causing vaginal bleeding. Aspemifene is also called Aspema. This is a selective estrogen receptor modulator is the category. It's an oral tablet taken once a day with food. It's indicated to treat discomfort with intercourse, moderate to severe dyspareunia. And there's some hope that this would be shown to be helpful for the breast, though that hasn't borne out yet. But some women prefer this because they just don't want to go through the rigmarole of having to use a vaginal preparation. Another newer agent is called prasterone. This is also called Intrarosa. This consists of a hormone called DHEA. We used to think this was going to be a hormone, when taken, would be kind of a fountain of youth. That didn't pan out. But when used vaginally, it turns out that it's metabolized within the vaginal tissue to both estrogen and testosterone, which is an important hormone for women. And that these levels, though, are very low. They are still well within the normal postmenopausal range, and it can be very helpful from a vaginal standpoint. It shouldn't be used if you have undiagnosed abnormal genital bleeding. As I've said a number of times, you want to get this checked out. And again, they have a warning and precaution for use with breast cancer, but this is something that I think is still being sorted out. So the summary for the genitourinary syndrome of menopause: if your provider hasn't asked you about vaginal symptoms or vaginal dryness, be bold and ask them. We really encourage people. I tell our medical students, do your patients a favor and just put it out there, but it doesn't always happen. So be bold and ask. We think vaginal estrogens are very safe when the current doses used are low, but as I mentioned, report any vaginal bleeding. And just, I have to say, don't be dismayed when you get home with your vaginal estrogen. Open it up and read the package labeling, because the FDA has required that that the manufacturers provide the same labeling as for any dose of systemic estrogen. So the labeling will caution about heart attack, stroke, breast cancer, dementia, the things that I kind of commented to you. We just do not think that's the same. And some of us have gone to the FDA through the years and asked to have these labels changed. So please don't let that put you off from trying this therapy. And finally, it's fun that the new products have come out and gives people a choice. So the last moments, I want to just talk about what else can we do when we think that it's the official number, I think now, is like 40% of our lives after menopause. That's almost half. So what can we do to really make these the best years ever? I like to say that the menopause is a portal to the second half of life. That this is, yes, it's a passage. Yes, it can feel arduous at times, but I can guarantee you it does pass. But it's a critical window to look at how we're living. What am I doing with my lifestyle? What can I do differently? What's going on right now with my health concerns? What things run in my family that I'm always kind of worried about might come up with me? And what can I do to be more proactive about my health? And so I already mentioned heart health. You can tell I'm kind of into heart health. I am. This is the number one killer of women, women with diabetes for sure, all women. And trust me, anything good you think about and do to improve your heart health is going to improve the heart health of your whole family. So keep that in mind. I am really happy and heartened to see that in the medical literature, for the first time within the last couple months, there's been a new article in this really top drawer journal called Circulation, highlighting that the menopause transition may be related to cardiovascular risk. We need all of our doctors and specialists thinking about some of these normal transitions for women and ways that can affect us. So what can you do right now? Just the straightforward things about risk management that you know about. Keep your blood pressure under control, keep your diabetes under control, do what you need to do to keep your cholesterol levels under control, and triglycerides. Triglycerides are getting more important. And then really take the lifestyle stuff seriously. I read a report where women who followed all these categories of healthy lifestyle could actually extend their life after age 50 by about 15 years. Think about that. That's a graduation, that's a wedding, all kinds of good things. And so the American Heart calls these straightforward points life's simple seven. Realistically, not so simple to do all this. I get that. But we can look at just going around the wheel here, the healthy eating and the exercise that are going to have an impact on the scale. Even 7 or 8% weight loss can really help with, if you have a type 2 diabetes, with your glucose management. And it is possible, depending how long you've been diabetic and what degree of diabetes, that this can kind of get better. We know that it's important to keep the blood pressure under control, keep the glucose under control, and keep the lipids under control. And please just don't even talk about cigarettes. Just make those go away from your list. A couple other things for women. I mentioned osteoporosis earlier. Please, don't hesitate to say to your doctor, I heard this really good talk. And she said that I should ask you, since I'm a woman living with diabetes, what about my bones? Should I have my bone density test? Should I go through a risk calculator? Do you think I might need treatment for this? What's going on? Similarly, please be aggressive at your cancer screening. I talked about mammography. Don't skimp on your colorectal screening. And again, any unexpected vaginal bleeding, get that checked out. If your partner says to you, babe, you're starting to snore, we know that menopause contributes to obstructive sleep apnea, and we know that this is accentuated in women with diabetes. Obstructive sleep apnea does all kinds of crazy things to our blood pressure, to our heart rate, and can lead to a real increase in cardiovascular risk. So easier to check it out. We can do home sleep studies now. You don't have to go to a lab, but go ahead and bring that up when you have your checklist. Again, from a cognitive standpoint, the best thing we can do is take care of our heart, and our brain is going to benefit from all that. And a lot of the depressive symptoms with the menopause change get better once you get through that. And we've just talked about genitourinary syndrome of menopause. So in our presentation today, I hope you've learned more about what menopause really is and what it isn't. I hope I've reassured you that we have a really impressive menu for symptom relief. And sometimes women need to appreciate that it can be a bit of a trial and error. So don't give up if the first thing you do isn't working out. Give it a little time and then try something else, because there are so many things available. And then finally, bear in mind the positivity of going through this transition, that you will get to the other side. You'll get to the top of those steps. And then it's a time to celebrate and consider all the other things we can do to enhance the rest of our life. So I thank you for your attention. Again, I congratulate Dr. Edelman and his team for putting this together and for enabling us to do this virtually. And I hope that you will feel better at this time about taking control of your menopause too. Okay, thanks so much for your attention.